No brainer at all. Ovarian cancer with the PARP inhibitor. Everybody is coming up with this molecule, and we all know the indications, but still, we'll go through it. If we go through the NCCN guideline, according to the either breast, there are many indicators, ERP or HER2, as well as BRCA1, BRCA2, PIK3CA, ESR1 mutation, P10 mutation, AKT3 mutation. And specifically, if we talk about the ovary, there are only three molecular based treatment which is in process. Either it is a MSI for the immunotherapy, or a BRCA, or a HRD positivity or not. So, so for the ovarian malignancy we are talking about, so the ovarian malignancy, where the patient is either a germline BRCA1 or BRCA2 positive, or a somatic BRCA1 or BRCA2 positive, or a HRD with or without the BRCA positivity is considerable. So with all those consideration, so if the patient is either germline or somatic BRCA mutated, single agent, if you talk about just the olaparib is indicated in the maintenance setting after 6 to 8 cycles of chemotherapy, either neoadjuvant, adjuvant, or complete chemotherapy. If the patient is HRD positive and the patient is not having a BRCA positivity, the indication is approved with the bevacizumab. And in the recurrent setting, if the patient is having a platinum sensitive relapse, then it is approved. And fourth, whether there is a three or more than three lines of therapy. Study 19, which was the first study, whether at that time it was a capsule, and it was not for the maintenance, it was for the treatment as well. And other from that, olaparib is approved in breast cancer, prostate cancer, and pancreatic cancer as well. So if we talk about the ovarian cancer positivity, if if we are seeing the germline positivity of the BRCA, it is almost from 13%. Going to the germline plus tissue BRCA, it is almost 22%. And if we going about the HRD, is almost between 45 to 50% of the patient do have a HRD positivity report. Uh, Again, moving forward with the first line maintenance therapy, olaparib with or without bevacizumab was approved in the 2018 with the BRCA mutated patients, only with a single agent olaparib. With the HRD positive with or without the BRCA, it was approved with the Paula-1 trial in 2020 along with the bevacizumab. Niraparib, although not approved and we have not used, it was approved across the lines of therapy. Either it was a BRCA or a HRD, and along with that, if we talk about the rucaparib, it is also approved, endorsed, but not FDA approved till date. But yeah, it has shown the results at par. Either the patient is HRD positive or not, or BRCA mutated or not. So basically coming to the main trials, Solo 1 trial for the olaparib showed in the BRCA mutated patient the hazard ratio 0.3. The HRD positive patients in the Paula-1 trial, it was those the patient who are having HRD as well as BRCA. Again, the hazard ratio is 0.3, but those the patient who are having a HRD positivity with the BRCA wild type was 0.43. And again, those the patient who are having a HRD negativity along with the BRCA wild type, it was almost hazard ratio was 1. So no, probably no, not a good response. Again, the primary trial, again, niraparib is not approved, so I do not have any experience for that. An Athena trial, although showed a very good result in either the patient is BRCA mutated or not, HRD positive or not, but still, since the FDA approval is still pending, I myself do not use RUCA as such in these indications. So again, coming back to the olaparib, starting from the olaparib solo one trial, those the patient who were BRCA mutated had in the placebo arm, it was a 13.8 month of PFS versus overall survival of more than 56 months. And those the patient who are having in the Paula 1 trial, whether either the BRCA mutated, again, though hazard ratio was almost similar, the PFS was between 17 to 21 months in the BRCA mutated arm or HRD positive arm, the placebo, versus in the treatment arm, which was olaparib with the bevacizumab, it was almost around 37 months. So intent to treat population, although showed a significantly higher response, but that was due to the inclusion criteria. But those the patient who are having a negative HRD or BRCA did not show any benefit. If we again talking about the if you see about the Athena trial, BRCA mutated patient had a PFS of 14 versus not reached, and HRD positive of PFS was 11 versus 28.7 months, which was not reached. And if we talk about the Prima, again, similarly, between 8 to 10 months of PFS in the placebo, or between 20 to 22 months of the PFS in the interventional arm. So we all know about the solo one trial with the patient of advanced C ovary, either stage 3, stage 4, either high grade serous or endometrioid carcinoma with the BRCA mutation positive. The patient who responded initially on the platinum based chemotherapy, underwent a cytoreductive surgery, was randomized between 2 raised to 1 between olaparib and placebo. And in the primary updated trial, the PFS was not reached versus it was 13 months in the placebo arm, and the overall survival median PFS was median OS. I'm sorry for the typing mistake. Median OS was 56 months versus 13.8 months in the placebo arm. So this was it. 7 years of follow-up. 67% of the patient was still alive at the end of 7 years versus 46% in the placebo arm. And the conclusion said that there was a 40% benefit which showed with the PARP inhibitor therapy, if we compare about with the chemotherapy standards, with the hazard ratio of 0.55 and with the significant overall survival ratio. Again, if the Paolo 1 trial, whether those the patient who are HRD positive with or without the BRCA status, again randomized between olaparib with the bevacizumab. Again, the inclusion criteria was same, either stage 3 or stage 4, with the I grade, either serous or endometrioid carcinoma or fallopian or peritoneal cancer, which was randomized 2 raised to 1 ratio between olaparib to bevacizumab versus only bevacizumab with the placebo arm for 2 years. And bevacizumab was given for only for 15 months, and the median PFS was at the end of 5 years, it was 46% versus 19%, and the median PFS was 46 months versus 17 months only. And if you talk about the overall survival, median OS was 75 months versus 57 months, and the 75 months was also unstable because of the maturation data is not more than 50%. So patient benefited all across the data. The patient who are HRD positive, median OS was 75 versus 57, including those the patient who are HRD positive as well as BRCA mutated. Again, the PFS was OS was 75 versus 66, and those the patient who are HRD positive but are not having a BRCA mutation positive, median 5-year overall survival rate was 54% versus 44%. So again, irrespective of BRCA status, the inclusion of olaparib along with the bevacizumab give a overall survival benefit. But if we look across those subset of the patient who are having both HRD negativity and BRCA negativity, those the patient are not getting any benefit. So probably due to intent to treat population, the data is like that. But as far as now indicated, either HRD positive or BRCA mutated patients in the Paula 1 trial is a way to go again. And the incidence of MDS, which is a very significant side effect, is very low, and yes, a considerable option for the HRD positive patient and newly diagnosed and advanced ovarian cancer as a maintenance setting. So again, those the patient of stage 3, stage 4 who have not received bevacizumab in the first line setting, or the patient who are having a wild type, either observe or rucaparib or niraparib, or those the patient who are having a germline or a somatic BRCA1 or BRCA2 positivity, either olaparib or ruca or niraparib is the way to go. And those are the patient who has already received bevacizumab in the first line setting, and those are who are having a BRCA wild type, then we have to see those the patient who are having a HRD positivity, then bevacizumab with the olaparib, HRD negativity, then only bevacizumab, and if BRCA1 or BRCA2 mutation, then either we can go with the single agent olaparib or olaparib with the bevacizumab as well. So, relapsed ovarian, if we talk about the treatment of relapsed ovarian cancer, so initially it was like partially sensitive ovarian malignancy, which was like relapsing less than between 6 to 12 months, or platinum sensitive disease was relapsing after 12 months, or platinum resistant disease, which is less than 6 months of end of the treatment. But though these lines are quite merging right now, but till date, now for the maintenance setting in the second line for the PARP inhibitor, it is still the same. So coming back to again the role of PARP inhibitor in the management of relapsed ovarian malignancy, it has to be germline BRCA mutated. It has to be platinum sensitive disease. Just for the information, so whether they have approved for the HRD positivity or HRD negative, it is for the study 19, which was initially approved from where the olaparib introduction started. So a solo 2 trial for the second maintenance setting in the after the second chemotherapy, again showed a median PFS of 19 versus 5.5 months, and median overall survival of 51 months versus 38 months. And study 19 was the the initial study of olaparib, where there was a capsule of that, and it showed a very good response. It was again compared between the chemotherapy and showed a very good response. And solo 2 again in the second line setting showed a hazard ratio of 0.3 in the PFS and hazard ratio 0.7 in the OS setting. So influencing what are the factors in the PARP inhibitor choices? It can be a biomarker, dosing schedule, interaction, adverse effect, and the patient provider preferences as well as financial consideration as well. We all know the starting dose of the PARP inhibitors and the toxicity management. So, and if we talk about the toxicities, we can all the PARP inhibitors, if we talk about the olaparib is almost least having a side effects. If we talk about the cardiovascular, highest is the niraparib. If we talk about the skin effects, rucaparib is on the higher, and GI again the rucaparib. Hematologically again the niraparib. Again, if you talk about the liver toxicities, again rucaparib is on the higher side. If you musculoskeletal, renal, or respiratory, again niraparib or either rucaparib is on the higher side. So most tolerable PARP inhibitor till date is olaparib, and we do feel so in our clinical practice as well. And these are the monitoring criteria when we can hold either hemoglobin is less than 6 or platelets is less than 1 lakh or ANC is less than 1,000. We need to hold the drug, and there is a standard guideline. We are not going in the details with them. So thank you so much, Devis sir, for giving me this opportunity. And
So, thank you, Ankit. So, what is your? Are you doing the BRCA in all patient upfrontly?
so, sir, this is a very very so I do BRCA in all those patients who are quite affordable, at least for the olaparib or HRD, who are affordable only. If they're not affordable at all, I'm not pushing them for any testing
I think this
because
time financial consideration, but can we send upfrontly the sample for the germline initially? Then we can decide for the HRD in upfront first line setting.
yes, sir. I'm sending first line setting from the starting of the treatment. Germline is I think. So I am a garibo wala doctor, sir. So I send free of cost germline BRCA
Yeah.
for all the patients.
Asim, is your thought about this? The ovarian cancer you are treating this segment in this Bhagwan Mahavir?
Ankit, Deveshji, we are sending and we are try to send in each and every patient now.
Okay.
And no doctor should be Garib, even if they treat the Garib patient. Doctor should be always like Dr. Somani. At least
You can
So
और पीछे
send
उनकी इतनी
yeah.
बड़ी बिल्डिंग दिखना चाहिए.
you can
Yes,
send
yes.
them to the government setup because they claim that each and every treatment is free of the cost and equally available to everyone.
Yes, sir.
So, sir, just let me complete my what you asked there. So, germline BRCA, I am sending for all the patients, just for the screening. And if the patient, if either affordable for 15 to 16,000 or 17,000 rupees of olaparib, we are trying to counsel them for the HRD. Or if the germline BRCA is positive, then there is no issue. So with this approach, I have almost managed 10 patients in quite like last 1 year. So I am having 10 patients of olaparib just because of this as a step by step. Dhire, 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 dhire.
So, sir, just want to ask, sir, is there any starting dose 200 BD or 250 BD or upfrontly 300 BD?
300, sir.
Can I ask a question?
Yes, sir.
Dr. Ankit and to Dr. Samar also because he probably had the large experience of giving this drug. There is a typical scenario, stage 3 high-grade serous carcinoma, upfront surgery is done, beautiful surgery, everything is okay, and patient is receiving bevacizumab also. Now, on the one hand, you say that the rucaparib is for each and every patient, irrespective of the HRD of the BRCA positive. And you have the BRCA positive and the option of the olaparib also. So, how you choose between the two situations? And if the rucaparib is there for every patient, irrespective of the HRD, what sort of the magnitude of the benefit difference you think that HRD positive versus HRD negative in context to the rucaparib versus olaparib? Ankit,
Should I start, sir? So, first of all, sir, Rucaparib is not a good drug to tolerate with. Na? So, patient do have a very high dermatological reaction, diarrhea, and everything. So, if it is a germline or wild type BRCA mutated positive patient, I give them an option. If you are continuing the bevacizumab, you can continue, or you can just start with the single agent olaparib. I had a very terrible experience with the rucaparib. Although five out of five, only one patient is tolerating full dose. Otherwise, all four patients are discontinued because of the side effects. For the rucaparib, I'm saying, sir. Very terrible. Those the patient who are complaining that even the chemotherapy was quite tolerable than the rucaparib.
This is fact actually. Sir, we have tried once when the Olapari was very costly and when you were using Linparja. So that time we used to use the Rucapari, but we all know like it's not a tolerable drug. One thing is not tolerable and other thing is the effect is also we can't see. Patient is symptomatic as we started and he remains symptomatic. She remains symptomatic. So this is a basic issue. So our trust is on the Olapari. Now the generic will come and we'll see how they works, but still the original one is good drug to tolerate and the effect we can see both the ways in the response with the the symptom and the duration of the symptomatic relief. So all are there. So we believe on that.
So dosing, if you start with 250 BD or 300 BD upfrontly?
300 BD. 300 BD.
Upfrontly.
And I must say, very rarely we need to reduce the doses of the this Olaparib.
Okay.
I
And
agree
are you
with
comfortable with this generic drug? Abhi, that time the drug was launched and you are giving, so you are comfortable compared to the research molecule?
Yeah, it is.
Sir, I agree with Asim sir. I've seen like almost 70 to 75% patient, one, two, three-fourth of the patient tolerate very well the full dose of the drug. And it is very early to say that whether the generic is doing good or not. But one of the patient waited after this, he has started the olaparib. She has started the olaparib in the second line setting, and she waited after the completion of chemotherapy for 3 months. And her CA-125 was almost around 75, but there was no radiological disease. And she started taking some generic, I do not know with the hot melting technique and everything. And within 15 days, the CA-125 came to 7. So I think generic is also working, but we cannot see the PFS and OS, but this is a small data like we can observe. So I think it is working. Or
Is there any difference of making this drug in the suppose some techniques are they some companies are claiming hot and mac? I think I don't know.
सब वही कर रहे हैं सर, सब वही कर रहे हैं, वो सब मार्केटिंग है सर. Everybody is creating that only.
So thank you sir and thank you Ankit for
Thank
this
you sir. Thank
talk.
you sir.